last scenario, where running a little bit of short of time, we'll find out pretty quickly. Sir, there is a middle-aged woman, previous three cesarean section. She is now undergoing another elective cesarean section. During surgery, patient starts breathing heavily. Due to dry atonic, gynecological team decided to proceed with hysterectomy. Family was informed about the situation, but they refused and they didn't give any consent for the procedure. Meanwhile, patient situation started to deteriorate and surgical team proceeded with their plan without family's consent. Post-operatively, patient remained stable and was shifted to medical ICU and the case was over. But after the procedure, the family sued the whole team involved in the procedure for doing hysterectomy without their consent. Now, what should be our point and how can we save ourselves and how should the case be proceeded further?
My question is, has the anesthesiologist been also be called in this?
Anesthesiologist was on table and
so he has been summoned by the commission or by?
Yes, the entire team has been summoned because anesthesia was given for a cesarean section. Hysterectomy was planned afterwards.
This scenario is very important, but let me know. Were the attendants taken on board when the patient was?
Yes, they were taken on board. They were told about the patient situation getting serious and uterine atony is not being corrected by all the maneuvers, so we proceeding with hysterectomy. But they didn't give the consent.
Okay, the patients deteriorated and they did not sign for the consent.
No, they didn't sign and they asked us do whatsoever but save the
uterus. They even did not sign this consent that we are not willing for hysterectomy.
Yes, no, they didn't sign it, but they just verbally said, just save the uterus and proceed with the case.
So, there is nothing further. If we have taken the attendants on board and they decided that we are not proceeding for hysterectomy, it should have been documented.
Okay.
And then they have given informed consent or a consent that we are not willing for hysterectomy, then PPH will.
Okay. Means that time everything should be documented according to the question.
This is very important. Whenever we are called to the commission, the major drawback on one is communication gap,
exactly.
Two is consent. Patient was passed center line, was consent taken? No.
Who passed?
Patient was put on ventilator, was consent obtained? No. Then the problem is with that person who put the patient on ventilator. If you keep in touch with the patient or attendant and you inform each and everything, the problem can be minimized.
Sir, says everything should be documented. Even the refusal from the family should be documented. किसी हम refuse करते हैं, we are signing a consent. किसी आप proceed करें, we are not concerned with the patient's right. तो वो भी documented होना चाहिए to save ourselves. जी मैडम आपको चाहे तो.
Yeah, thank you very much for this. A lot of senior people are sitting over here, and I see Professor Farooq is one sitting and smiling, and I know what he would say to this. He would say that he would do hysterectomy in the best interest of the patient, even without a consent. I can say that for sure. And you know why do I say this? The thing is, the first thing is you have to follow procedure.
Okay.
The second thing is that the team, which includes the surgeon and the anesthetist, should be convinced that whatever needed to be done has been done. All the steps and the processes and the PPH bundle approach, whatever the steps are, have they been done? Is there evidence of blood loss to an extent which is life-threatening to the patient?
Okay.
Is there evidence of change in the blood pressure and the heart rate which would protect you to say, and is the hemoglobin low enough to say that if we do not do a hysterectomy at this point in time, the patient will die? Okay. If you have all this, the first thing is that you are lacking communication when you are not talking to the family. No family in the right frame of mind would ask you not to do a hysterectomy if the patient is dying. But let's presume that there is this family who do not want to have it done.
Exactly.
Even then, in the best interest of the patient, the surgeon can do it. The issue is, do we not go into litigation ever? We do. Yes. Even senior people, and we used to have one of our foreigners, his name was Professor Chris Hudson, who came to us for a project that we did in Pakistan. He was a very senior gynecologist in UK. Even he had litigation against him. So one should be not scared of doing the right thing. If you are doing the right thing and you have evidence that you did the right thing, then I think you could go for it.
That's great. Thank you, madam. Anyone from the panel, from the chair, wants to add on something to add on this scenario?
Just one word. Basically, the outcome depends on the litigation होनी है. Litigation अगर outcome ठीक है, healthy baby, healthy mother. after the operation or after the surgery or normal delivery. अगर आपका आउटकम ठीक है और ऊपर इसके मेल बेबी है तो लिटिगेशन नहीं, अगर फीमेल है या चेंज हुआ है उसका डॉक्यूमेंटेशन में, then there is likely litigation. तो आपने सारी चीजें आपके आउटकम पे हैं, आउटकम आपका बेहतर करें, सर्जरी में भी, एनेस्थीसिया में भी, लिटिगेशन मिनिमल हो, और that depends on your knowledge, your communication skills and better documentation. हर चीज का डॉक्यूमेंट करें अब जाके। एक चीज थी आर्मी की, उन्होंने बताया कि आर्मी में बहुत अच्छी एसओपीज हैं, डॉक्यूमेंटेशन भी है, वहाँ कोई भी एडवर्स आउटकम होता है तो उसकी इन्वेस्टिगेशन होती है, वहाँ पे हेल्थ केयर कमीशन का कोई बहुत ज़्यादा दखल नहीं है, लेकिन वो इन्वेस्टिगेशन में सबसे पहले डिसाइड हो जाता है कि सजा क्या देनी है, किसको देनी है और कितनी सजा देनी है, उसके बाद इंक्वायरी चलती रहती है।
पहले सजा डिसाइड हो जाती है, इंक्वायरी बाद में रेट्रोग्रेड। चलिए सर, थैंक यू सो मच सर, बहुत बढ़िया सर।
इसमें was there any pre-existing risk factor in this patient?
Sir, previous cesarean sections हो चुके हैं, fourth time she's going through it. Otherwise, there was no epita, family was not informed.
Well, suggestion over here, if you have a patient in which you are expecting risk like this, if you most of the patients in pre-op area, pre-anesthesia,
That's a very good point, which
then
is
I think the problem can be.
if counseling अगर previous 4 है तो वो should इसकी भी थोड़ा सा
explain
explain होना।
already previously or middle age में मैडम कुछ बोलना है।
मिडिल एज के लफ्ज से तो मैं एग्री नहीं करता। आजकल कोई मिडिल एज नहीं होती, मतलब व्हाट इज द नंबर ऑफ इयर्स दैट यू विल पुट टू मिडिल एज में कुछ नहीं। और दूसरा मैं ये कहना चाहती हूँ कि इन अ पेशेंट विद whom you are doing even a fourth cesarean section, you might mention hysterectomy in the passing, but if you say that you are going to end up doing an hysterectomy, the patient will not
Yes.
come to you.
Excuse me. Sir, आप कहें प्लीज।
सर मैं सिर्फ ये कहना चाह रहा हूँ कि नो कंसेंट का मतलब ये तो नहीं है कि डेथ कंसेंट दे रहे हैं रिलेटिव्स उसके, तो इसलिए कंसेंट जो चीज़ हमने करनी है वो तो करनी है। इसके लिए जो इम्पोर्टेंट चीज़ ये है कि काउंसलिंग कोई फिर बात होती है कि आपने बात की है किसी से नहीं की। हमारे ये सिनेरियोज डेवलप होते रहते हैं, एक्विटास और ये चीज़ें अक्सर आ रही होती हैं, हम सबसे पहले काउंसलिंग कर रहे होते हैं उसकी, फिर उसके बाद एक एमडीटी करते हैं, मल्टी डिसिप्लिनरी टीम एक आ रही होती है और वो डिसाइड कर रही होती है, वो काउंसिल करती है पेशेंट्स को और उनके रिलेटिव्स को भी, और उसके बाद एक प्लान करके इमरजेंसी सर्जरीज तो है, ठीक है इमरजेंसी सर्जरी है, लेकिन इसका मतलब ये नहीं है कि वो कंसेंट नहीं दे रहा तो आपने डेथ कंसेंट लेनी है कि पेशेंट मर जाए।
According to situation proceed करना है हमें, वो देखना है, patient to patient vary करना है। Thank you so much to all the worthy panelists and chair members. Any question here, please? Sir, come on.
Yes, I have some comments on this. For value clarification, would you want the patient to die or to just save your skin? As doctors, we are open to litigation and medical legal aspects. And should I be afraid of taking up an important and life-saving decision for a patient just for the fact that I might be put into a medical legal situation? And if the patient dies, then how are you going to absolve yourself of the guilt and also from the medical legal aspects of that? So there is absolutely no point in this. You must have seen so many times in cases of placenta accreta, when initially we try to save the uterus because we don't want to go ahead with the more traumatic procedure of hysterectomy, and if one can save that, we do. And many a times the anesthesia team says, please go ahead for hysterectomy, don't waste time with that. And thirdly, in this scenario, the decision is the surgeons. So, or obstetricians. And if anyone is to be blamed, it will be the obstetrician who will be called for questioning, not the anesthesia team. The anesthesia team has to support the obstetrician and act as rather witnesses to the dire situation that the patient was in, which required that hysterectomy. So I would not hesitate at all if there is some step to be taken to save the life of the patient. And at that time, I don't really think I'll be thinking about medical legal aspects of that. my total attention, my total focus would be on saving the patient.
Sir, I think it is very well summarized. You have completely summarized the patient is our priority. In any kind of such situation, we should be saving the patient and leaving the medical legal litigation behind. If done, we'll face it afterward. But on table, patient is our priority. Patient safety is our main mission. Thank you so much, Dr. Farzuman, for adding so good point to the discussion. So anybody from the
एक छोटा सा अस्सलाम वालेकुम।